So thank you very much for the opportunity to present in this webinar on addressing hepatitis B as a public health problem. The presentation I'll make is going to talk about the public health and clinical considerations with respect to the management of hepatitis B and also include some slides on the elimination of mother-to-child transmission. So my name is Nick Walsh. I'm a physician and currently work as the regional advisor for viral hepatitis at the Pan American Health Organization based in Washington, DC. This webinar is a consequence of the meeting, the Caribbean regional meeting on hepatitis was held on May the 23rd in Port of Spain, Trinidad, this year, 2018. So first of all, I'm really basing this talk on four key documents, or four groups of key documents, and these documents are available online on the WHO website or on the PAHO website. You can just Google them, and the first hit will be these documents. So the first document to be aware of is the Global Health Sector Strategy for Viral Hepatitis 2016 to 21. This is a document that was taken to the World Health Assembly. Where countries agreed to eliminate hepatitis B and C as a public health problem by the year 2030. So that was a significant event. And so everything we do in PAHO is geared towards assisting and supporting countries to meet their goal. The second document, in fact, preceded the Global Health Sector Strategy. It was the Regional Plan of Action for Viral Hepatitis for the region of the Americas. And we are more than halfway through that plan of action. It's aligned with the Global Health Sector Strategy. It was approved by member states in the year prior to the Global Health Sector Strategy. And this really guides some of our work regarding the implementation of those key interventions which are necessary to support elimination. We have WHO guidelines for hepatitis B and C testing. These are available online. Simplified algorithms for testing the testing of hepatitis B and C. And finally, we have the treatment guidelines, the WHO guidelines for hepatitis B treatment. And in fact, today, were released the new hepatitis C testing treatment guidelines. They were released in Mongolia today, and they call for a treatment of all people living with hepatitis C with pan-genotypic regimens. So a very important day for us as WHO PAHO. So I'd like to focus on what are our key actions to address hepatitis as a hepatitis program at PAHO. Really, we are focused on mobilizing action at the country level towards the elimination of hepatitis B and C, and through a number of different key areas: national action planning, disease burden investment case, access to medicines and diagnostics, data systems, integrated centralized data systems, and of course advocacy and community participation. EMTCT Plus is a new initiative. All of these actions, these areas of work, focus on supporting countries to eliminate viral hepatitis. So if we turn to hepatitis B, what's the burden of hepatitis B in the Americas? Well, it's approximately 3.9 million people across all of the region. If we look at hepatitis B in the Caribbean, approximately 900,000 people are chronically infected with hepatitis B. Now, we're limited by data. There are very few countries that have representative sero-surveys estimating prevalence, and so that's why you see many of the prevalences are 2%. Is really extrapolated data. Likely the number of people living with hepatitis B is probably a little bit less in some countries, maybe a little bit more in other countries. If we turn to the impact targets of the global health sector strategy, these are really the key targets we need to be aware of. There are two critical impact targets. One is to reduce new infections, the other is to reduce deaths. Our goal by 2030 is to reduce new infections for hepatitis B and C by 90% from the current level, and to reduce mortality by 65% from where we are now. So really, new infections are prevented through vaccination programs for hepatitis B and blood safety programs, safe injections, etc. for hepatitis B. For mortality, though, really it's all about treatment, getting people living with the virus diagnosed and getting them onto treatment. The plan of action for hepatitis, viral hepatitis at the regional level has 5 pillars of action, and these are consistent with the global strategy. Everything is aligned. The initial pillar is promoting an integrated, comprehensive response. Pillar 2 to access to preventative care. This is prevention interventions. Pillar 3, access to clinical care, so testing and treatment. 4 is data systems, supporting strategic information. And the final pillar is really strengthening the capacity of the health system to support the response. What I've put here is the cascade of prevention and care. Now, normally we talk about the cascade of care, but in this case, we've put together those aspects of prevention which are really important and feed into those aspects related to the cascade of care. So essentially what we want to do is focus on preventing infections. The critical intervention for hepatitis B, of course, is vaccination early in life. The birth dose is the most critical dose to prevent hepatitis B vaccination. Testing of hepatitis B or C. And for those people that are positive, they'll then go into the cascade of care, linkage to treatment itself, and hopefully people will be retained on treatment. Viral load is suppressed, or in the case of Hep C, an individual is cured. And if people test negative, of course, then they go into the prevention arm, where if they have not received the vaccine, you have catch-up vaccination programs. For adolescents, for example, that missed out on the initial birth dose, early life B3 coverage, or for example, health workers or other people that may be potentially at risk of acquiring hepatitis hepatitis B to be vaccinated. So just to look at why we do what we do with regards to hepatitis B. This is an example of the prevalence of hepatitis B in a country of the region. This is a one country in South America, but it's for illustrative purposes only. The hepatitis B prevalence by age and sex. So what I want you to notice is that the hepatitis B prevalence is really very low in those young cohorts, and this is a consequence of hepatitis B birth dose early immunization program. So you virtually have no hepatitis in the age groups below the age of 20. And then you get a sort of a peak prevalence in the middle age, and then the prevalence in age groups reduces over time. And we believe this is because of attrition. So this is people with hepatitis B are dying in the older age groups earlier, and so the prevalence in those age categories is reducing. So we really have to prevent new infections, vaccinate, and treat to prevent deaths. In 2017, WHO released hepatitis testing guidelines, and these are available on the web. There's a long version, a couple hundred pages, and there's a short version which is about 10 pages, which summarizes the key findings and the key recommendations. But essentially, there are a number of different categories to consider when we talk about hepatitis testing, hepatitis B testing. One is who to test. A program should focus on testing specific populations, really the most affected populations. And for hepatitis C, obviously that's clearly identified risk groups. For hepatitis B, it may be a little bit different, because of the sexual transmission, the family members, young people that could acquire hepatitis B early in life. Healthcare workers, an important cohort. And of course, anyone with a clinical suspicion of chronic viral hepatitis or with a family history of liver cancer. In those population settings where the prevalence is intermediate or high, greater than 2 or 5% respectively, for hepatitis B and C. So in the case of hepatitis B, if the population prevalence is greater than 2%, we would recommend general population testing. So that would mean that at least an individual would get tested at least one time in their life, in their adult life. Routine antenatal testing, the fourth bullet point here, is important, not only to understand the prevalence, but also to prevent transmission to infants, because we need to really know which pregnant mothers have the infection to prevent transmission to the child. How do we test? Well, a single serological assay, it's a rapid test or a EIA that meets minimum performance standards, is the screening test. And then you need to really confirm infection with respect to hepatitis C with a nucleic acid test. With hepatitis B, confirmation of confirmation of infection once someone is hepatitis B surface antigen positive is probably not necessary. But in the case of treatment, it's important to understand who has a high viral load and who has a low viral load, because that is one of the determinations of whether to treat someone at this point in time or to wait. Finally, in terms of promoting uptake of testing and linkage to testing and treatment, we do recommend dried blood spot specimens where PCR is not possible. Transportation issues potentially exist. Regarding rapid tests, this is really a new tool in the armamentarium. You can provide immediate or on-site test results using rapid tests, but the problem is that rapid test results do need to get reported into data systems, and often rapid tests are not reported, and so this is a key gap in many countries of the entire region. In fact, we are advocating lay health workers, perhaps peers in some cases, are able to test. So this is the concept of task shifting, and of course, where computer systems exist, then automated clinical reminders to prompt physicians or nurses to initiate facility-based testing. So, and all those and more, that information can be found online at our website, PAHO.org, and search hepatitis. So just moving on to treatment, hepatitis treatment is liver cancer prevention. This is a very important statement. About 80% of liver cancers worldwide are a result of hepatitis B or C infection. If you don't have the infection, you're most likely not going to get liver cancer if you don't have viral hepatitis. If you do have it, it increases your risk of liver cancer manyfold. So clearly, if you have the virus, we have effective treatment, and prevention of liver cancer can occur in the context of treatment. So really, if you are treated, if you have the hepatitis B infection, you receive treatment, you can reduce the risk of liver cancer by about 75%. The ideal scenario for any infectious disease which causes complications or, for example, cancer, is that if you have the virus, or the infectious disease, you would have curative treatment, and then following that, you'd have access to a vaccine. For those people not infected, they would have access to a vaccine. So you had the combination of curative treatment, highly effective vaccine, is obviously the ideal scenario. So what have we got for hepatitis B at this moment in time? We have an effective but non-curative treatment, reducing the risk of liver cancer by about 75%. We have a cheap, safe and effective vaccine. The treatment is relatively cheap. We can access treatment for not much, but although that's not always the case, depending on where it's procured and how it's procured. But it is lifelong in most cases. WHO released hepatitis B treatment guidelines in 2015. There were some key recommendations on how to stage liver disease, how to understand if someone has or has not got severe liver disease, cirrhosis, who to treat, what treatments to use first and second line, how to monitor, when to stop, and prevention considerations. So I'm just going to go through a few key points regarding the recommendations in these guidance. The first is that for hepatitis B treatment, we need to prioritize treatment for those that need it most. Mortality in chronic viral hepatitis is from cirrhosis and liver cancer. And so if you have cirrhosis, you really need to be treated. So we really need to identify who has cirrhosis and who does not have cirrhosis. What this does is really reduce the pool of people that need treatment, because if we look down the bottom of this slide, you can see on the left, estimated population living with chronic viral hepatitis. Once you test and diagnose people, you've got the diagnosed population, which is smaller than the estimated population living with viral hepatitis. But if you then stage liver disease, you can understand who is able to be treated, who needs treatment at this moment in time. And so the number and the scale of the intervention at population level reduces markedly. It's more manageable at a public health level. So why do we need to understand what are the key variables determining the outcome of hepatitis B, and why do we need to understand these when we think about who to treat? There are a number of key variables that we need to consider. The fact is that if you're a male and you have hepatitis B, your risk of developing hepatocellular carcinoma is elevated compared to women with chronic hepatitis B. The reasons are really unknown. People of an older age have a much higher relative risk of developing hepatocellular carcinoma. And so therefore, older individuals, when in doubt, should likely be placed on treatment. It's really a marker. If you have someone present to you who's of an older age, chronically infected with hepatitis B, these are the people you have to get into treatment relatively sooner. The DNA level, the viral load is an important determinant of liver cancer risk. People with high viral loads have a much, much higher risk of developing liver cancer. And so that's why we recommend people with chronic hepatitis B with high viral loads be treated immediately. And what's interesting is that the baseline ALT is also predictive of liver cancer risk. So in the context where there is no availability of DNA testing, viral load testing, it is possible if we have a look at the ALT level and the APRI, which follows score, to get a sense of whether or not we should be commencing an individual on treatment. So the METAVIR score, most people are aware of the METAVIR score, but just to go through it quickly, is really a mechanism of staging the level of liver disease an individual may have. F0 being no fibrosis, no scarring, F1, 2, 3, increasing amounts of scarring, and cirrhosis being F4, where the scarring of the liver is sufficient to impede function. And so we really divide, at least for the case of hepatitis B, a key decision point being if an individual has F4 cirrhosis or F0 to F3. Those with cirrhosis need to be treated now. Those with F0 to F3 need really to look at the viral load to make the decision whether or not an individual will need treatment. So if cirrhosis, determining cirrhosis is so important, how do we go about doing that? Well, in the past, every individual needed to have a liver biopsy to grade their liver disease. But obviously, that's painful, it's costly, it takes time, there are some risks. So in recent years, we've moved away from invasive tests to non-invasive tests. And really, there are two key tests that are used in most countries around the world. And first, one of them is the FibroScan, which is transient elastography, which is basically and there's a picture of it up in the right hand corner, which is really to this is an ultrasound machine which bounces sound waves off the liver and is able to tell how elastic the liver is. Obviously, if the more scarring you have, the less elastic your liver is, and so you can easily in a few minutes get a reading as to what level of fibrosis an individual has. The problem is that FibroScan machines are about $20,000 each. They're expensive. Obviously, if you do 100,000 FibroScans, if you have 100,000 patients a year, it becomes very cheap. But when you're looking at low volumes of patients to be screened, then obviously the cost per individual screened using a FibroScan machine is high. So we have in these guidelines recommended APRI as the preferred non-invasive test. APRI is the ratio, it's ALT platelet ratio index, and there are numerous calculators available online. And essentially, if you score greater than 2 as your APRI score, then it's likely you have cirrhosis, and so the indication would be that this person would need treatment if their APRI score is greater than 2. So it's cheap. You only need to be able to do ALT and the platelet score, and you have a relatively quick answer. So this APRI score is really useful in resource-limited settings. What's the evidence regarding non-invasive tests for liver disease? Well, if you have a look in the guidelines that we published, it goes into great detail. But certainly, if you look at the table on the right here, the APRI low cutoff, I want to focus on APRI high cutoff. You can see that the specificity of this test is high. So if someone scores above 2, you really know that it is cirrhosis. You can be pretty sure that it is cirrhosis. And if they're less than 2, chances are it's not going to be cirrhosis. Obviously, where there is doubt, getting a FibroScan would be useful. It's not always possible in resource-limited settings. But we did a pretty comprehensive systematic review of 79 studies on the diagnostic performance of these non-invasive tests, and so we're comfortable that this is a recommendation that can be implemented and is cheap. So regarding the actual drugs, the medications that we recommend for the treatment of hepatitis B, in those people greater than 12 years old, adults, we recommend only 2 medications, tenofovir or entecavir. These are recommended because they have a high barrier to drug resistance, and which has plagued some of the other medications that were previously used for the treatment of hepatitis B, including lamivudine, adefovir, etc. These nucleoside or tide analogs did not have a high barrier to resistance, so the resistance was common, and so we don't recommend these medications. So if you're going to start someone on treatment, it has to be tenofovir or entecavir. Tenofovir is much more widely available. It's also cheaper. It's used in the treatment of HIV, for example. And in the case of people that have been on other drugs, for example, lamivudine or depivir, where there is antiviral resistance, suspected or confirmed, we recommend switching to tenofovir. So tenofovir is really the go-to drug. Start on tenofovir if you get resistance, if you had treatment with other drugs, other antivirals, and you develop resistance, move to tenofovir. And entecavir is an example, is the alternative first-line drug. So here's an algorithm which really systematically goes through the steps one needs to consider when considering, does the person in front of me, the patient living with hepatitis B, need to be treated or not? The first decision point is, are they surface antigen positive or not? Obviously, if you have no surface antigen, you're not infected. If you're surface antigen positive, the next question is, how old is the patient? Do they have cirrhosis? So I'd really go for the cirrhosis first. Is this person cirrhotic? If they're cirrhotic, their APRI score is greater than 2, treatment recommended right now. If they're not cirrhotic, then you need to consider their age. Remember the table I showed previously showed that individuals with a higher age have a higher likelihood of liver cancer. So our recommendation is that if you are greater than 30, then you need to be considered for treatment. You move to the next stage. If you're less than 30, at this moment in time, you can defer treatment. So let's have a look at those people who are non-cirrhotic but greater than 30 years old. The next decision point is, what's the ALT? Is it normal? If it's normal, likely inflammation is low. We can defer treatment. If it is elevated, this is above the upper limit of normal, then we need the next decision point, which is a hepatitis B DNA test. This is a PCR, the viral load, and then our cutoff is 20,000 international units. Essentially, do they have a high viral load or not? If you've got an elevated ALT and a high viral load, then you get treatment. Now, if you have an elevated ALT but a low viral load, your likelihood of developing cancer is low, so we can defer treatment. And these people will need to be followed over time. So just going through it again, hepatitis B surface antigen positive, are they cirrhotic? Cirrhotic, yes, treatment. Not cirrhotic, less than 30, defer treatment. If they're over 30, what's the ALT? Is it elevated persistently over 3 to 6 months? Then get the DNA, viral load. Is it elevated? Is it high? Treatment's recommended. Low viral load, not recommended. At this moment in time, you have to monitor these patients. Okay, so what do you do when DNA is not available? As I said, we treat people without evidence of with cirrhosis. Of course, that's clear. But adults without evidence of cirrhosis or the APRI score less than 2, you can really base treatment on whether or not you have an ALT, which is persistently elevated. And so this is for resource-limited settings. The ALT is really a critical test. The bottom point here, continued monitoring all persons with chronic hepatitis B, and that's critical. What treatment to use? As I mentioned before, we want at the nucleotide side analogs with high barrier to resistance, tenofovir and entecavir. We suggested that the strength of the recommendation was strong, where there was a lot of evidence. And the quality of the evidence was moderate. For children 2 to 11 years, where treatment is indicated, entecavir as a first-line drug, and it's really because of the toxicity issues regarding tenofovir in the early in childhood. As I mentioned before, the evidence regarding antivirals with low barrier resistance was poor. We do not recommend these medications, and where there is resistance, the second-line drug is always tenofovir. How do we monitor? We recommend at least annual ALT and AST, the hepatitis B surface antigen, E antigen, and hepatitis B DNA levels. So that should be done at least once a year. Non-invasive test, APRI score, is useful in people not on treatment, also on treatment, I suppose, but to monitor whether people are progressing to to cirrhosis if there was no cirrhosis at baseline. We obviously need to monitor adherence. Toxicity, of course, tenofovir is associated with some renal toxicity in some cases, and so creatinine should be, a renal function test, creatinine should be done in all people prior to the initiation of antiviral therapy and then monitored on an annual basis. What about the risk of cancer? Because getting treatment for hepatitis B does not eliminate the risk of cancer. So in people with cirrhosis, regardless of age or other risk factors, we recommend ultrasound of the liver looking for cancer, screening for cancer, and alpha-fetoprotein testing every 6 months. This is particularly the case of people with a family history of liver cancer, regarding people without evidence of cirrhosis or an APRI score less than 2. If you're over 40 years and you have a DNA level greater than 2,000 international units, you've had the viral load done, then you should really be screened for liver cancer every 6 months. There is obviously some cost consideration here, and if large numbers of people are infected with hepatitis B, screening individuals every 6 months with an ultrasound alpha-fetoprotein can result in higher costs, but clearly the cost of screening is cheaper than the cost of treating cancer. So can you stop hepatitis B treatment? The short answer is no. All people with cirrhosis will require lifelong treatment. The reason we can't stop treatment is because of the risk of reactivation. Sometimes that can be quite acute, can be severe, and it can cause further liver injury. There are some situations where it's possible to discontinue antiviral therapy. These are exceptional, but in people without evidence of cirrhosis and who are monitored and can be monitored going forward, if they've lost the hepatitis B E antigen or seroconverted, and they have persistently normal ALT levels and undetectable DNA. So really that's a very small percentage of individuals living with chronic hepatitis B who've started treatment. So some implementation considerations. So those were the clinical considerations. In terms of addressing hepatitis B as a public health issue, what are the key implementation considerations? Well, comprehensive national planning, we believe, is critical. Countries need a national action plan really to coordinate actions across the health system. This is not vertical programming. This is integrated into normal health service delivery. It's got to be based on the epidemiological context and cover the various interventions and financing, of course. Simple and standardized algorithms across the continuum of care, testing to care and treatment. Strengthening linkages from testing to care so we don't lose people across the cascade. Integration of hepatitis testing care into other services, for example, HIV services, other health interventions, so we can increase the efficiency of the response. Decentralized testing and treatment. We recommend that primary health facilities promote access to testing and care. Task sharing. You really don't have to be a doctor to test. This can be done at lower levels of the health system. And of course, engaging community peers where appropriate to promote access to services particularly for risk groups where it's difficult to get access to these populations. Obviously at the health sector level, strategies for more efficient procurement, supply management, because it's clearly the case in some countries in the Caribbean that the cost of the medication, hepatitis B medication, is prohibitive, even though this drug, to the average price of tenofovir, generic tenofovir across the world was around $40 per person per year last year. There are some countries in the Caribbean paying much, much more than this. So, and this is a great burden to the health system. And clearly, number 8, data systems, important to monitor the quality of the individual the response. So what else is happening in terms of hepatitis? I just wanted to mention that today we did launch the new guidelines for hepatitis C treatment. And in fact, I wrote this yesterday, it's true. So today we launched them in Mongolia, calling for treat all with pan-genotypic regimens. As soon as I have a copy, I will distribute that to our focal points. World Hepatitis Day coming up on Saturday. The theme is time to test, treat, time to treat, and time to cure. And I refer to the PAHO hepatitis website. There's a variety of different materials available on the website, and we welcome these to be used at the clinical level, at the country level. So just a couple of slides on EMTCT Plus. I know that Judy's going to talk about this. We have a number of countries in the region that were already validated as having eliminated mother-to-child transmission of HIV and syphilis. And congratulations to these countries. Now, what we want to do now is add in hepatitis B to this idea. And, you know, this is really using HIV as a leverage to congenital syphilis, of course, to hepatitis B and the other way around. We had strong political commitment to the elimination of HIV, and now we need to move towards obtaining that for hepatitis B transmission. It's a public health approach. It's simplified, standardized, decentralized, integrated into the common maternal public health, maternal platform, maternal child health platform, and really we see this as an opportunity to bring a number of different vertical programs together. We have released this guidance, the EMTCT Plus manual, which has the objective of achieving and sustaining the elimination of mother-to-child transmission, HIV, syphilis, perinatal hepatitis B, and Segas by 2020. We have impact targets. I'd focus on the 0.1% of 5-year-olds, 4 to 6-year-olds having chronic hepatitis B. And this document is available online. Just a couple of considerations to consider, which would be cost analysis for the implementation of the recommended interventions to eliminate Hep B transmission through the common maternal child health platform. It needs to be really interprogrammatic implementation. You need all the different programs working together, coordination, again, or in addition with the private sector. And of course, and it would be difficult without political commitment. So we advocate for political commitment at the highest levels. So in conclusion, hepatitis treatment is cancer prevention. Simple testing and treatment algorithms are possible now. Treatment is not possible without diagnosis, of course. Monitoring requirements are minimal. Hepatitis, liver cancer screening could be an issue in some places. We're here ready to support you to increase the availability of diagnostics and treatment across the Caribbean. And indeed in any of the 6 areas of work that I had mentioned at the beginning of the presentation. And but particular focus on hepatitis B, elimination of mother-to-child transmission through the EMTCT Plus initiative. So thank you very much for the opportunity to present. Happy to take any questions now or later. We're available via email as well. Thank you.
Thank you so much, Dr. Nick Walsh. I'll now hand you over to Dr. Judy Nisbett.
Good afternoon, everyone. I'm grateful for this opportunity to share. Like Nick, I also presented in Trinidad some weeks ago, and I'll be speaking today on the elimination of mother-to-child transmission plus in Saint Kitts and Nevis. So Saint Kitts and Nevis, 2 islands, 1 paradise, the smallest sovereign nation in the Western Hemisphere. We have a total landmass of 261 square kilometers, and most persons live on Saint Kitts, 26% live on Nevis. We have a male-to-female population of 1:1, and 27.3% of our population are under 15 years and 10.6% equal to or greater than 60 years. As most of you are aware, Saint Kitts and Nevis was validated as having achieved mother-to-child transmission. Sorry, I'm having a little problem with the screen. Okay, I'm sorry. So Saint Kitts and Nevis was validated as having achieved dual elimination of mother-to-child transmission of HIV and syphilis in 2017. And this came after 3 years of hard work collecting and analyzing data to demonstrate that we had achieved the targets and indicators for having eliminated mother-to-child transmission of HIV and syphilis. We reviewed data for 2012 to 2016 for both Saint Kitts and Nevis, and that's our Minister of Health receiving the award from Dr. Etienne. Now, elimination of mother-to-child transmission of HIV and syphilis was implemented on the maternal and child health platform, and that allowed for successful implementation of the strategy. And there were some key lessons that were learned. We learned that there were antenatals who were moving between the public and private sectors, and so all the data may not have been always collected in any one place. So we knew going forward that data collected at public clinics should reflect what is collected in both sectors. We also recognize the need for testing and treatment dates for clients at antenatal clinics, booking, and labor ward to be properly recorded and easily retrieved. We recognize the need for implementation of a surveillance system to capture data for maternal and perinatal services. We also recognize the need for standardized protocols and algorithms for clinical management of syphilis to be utilized across the board, because we found that sometimes the protocols and algorithms that should have been used were not being used. We realized the need for good lab services that were consistent and reliable, and that lab results, especially positive results, should be reported to the service provider and to the clients in a timely manner. And now the lessons learned in the elimination process for HIV and syphilis were needed to support the elimination of hepatitis B. I invite you at some time to look at the immunization newsletter by the Pan American Health Organization, December 2016. And in that newsletter, you would see an article about the reintroduction of the birth dose of the hepatitis B vaccine. This, of course, is in addition to the existing strategy of the 3 doses of hepatitis B vaccination that was used even before the introduction of the birth dose. The vaccination coverage was 98% in the first year in 2016, And this, of course, was due to the political support that the political will of the leaders, the campaigns that we did, and the public's confidence in the immunization program. But to give you a little background, in 1997, the hepatitis B recombinant monovalent vaccine was introduced in children under 11 months and also in ages 11 to 12 years in all primary schools. We also extended the vaccine to vulnerable populations as part of Vaccination Week, for example, sanitation workers, health workers, law enforcement officers. The pentavalent vaccine was introduced in 2000, and that was given, or is still being given, at 2, 4, and 6 months. The Federation collaborated in 2012 with CAREC and PAHO to conduct a hepatitis B seroprevalence study. And we had representative samples from both private and public clinics. And what we found was that there was a 3.2% of pregnant women were tested positive for the hepatitis surface antigen, and 52.4% tested negative for the antibodies to the surface antigen. Our findings were used to update our immunization policy, and we introduced the birth dose in 2015. And like I said before, in 2016 and 17, we had 100% acceptance and 98% coverage in 2016 and 97% coverage in 2017. And we did not have full coverage, of course, because some babies were born preterm. Now, based on the challenges and the gaps that we encountered during the elimination exercise for HIV and syphilis, these were used to strengthen the services for antenatal patients. Sorry. Okay. So based on the gaps and challenges that were noted during the validation process for HIV and syphilis, a national EMTC plan was developed in 2017. And that included strengthening of services and surveillance for hepatitis B in pregnant women. Again, the maternal and child health platform was utilized to strengthen the testing services for all 3 infections. So now we have added hepatitis B testing across the board for all pregnant women. Prior to this, a few private doctors would test. However, now everybody's been tested, both in the public and private sector. And that started this year, January 2018. Now we are recording the hepatitis B test in pregnant women in our maternal and child health registries, and we have introduced the perinatal information system in all public and private clinics. In some clinics, it's paper-based. However, in Nevis, all private and public clinics have introduced the electronic perinatal information system to collect the results for HIV, syphilis, and hepatitis B tests, and the birth dose, which is given within 24 hours. And of course, all other antenatal services that are given to the pregnant woman. The hepatitis B birth dose is followed by the 3 doses that I mentioned before at 2, 4, and 6 months of age. We have updated all our national policies, the algorithms for care and treatment for hepatitis B and for HIV and syphilis have been developed and being utilized in clinics. We have trained our healthcare workers, and that's ongoing. We treat our affected babies with hepatitis B immunoglobulin within 24 hours of birth, along with the birth dose, and they are followed up. Any exposed infants are followed up by the pediatrician and at child health. And we plan a seroprevalence study in 2020 for the first 2 cohorts of 2015 to 2016, so that we can support documentation of the elimination of vertical and horizontal transmission of hepatitis B virus. Thank you very much for the opportunity. So Saint Kitts and Nevis is moving towards ensuring a generation free of HIV, syphilis, and hepatitis B.
Okay, great. Thank you so much, Dr. Judy Nisbett. Thank you so much, Dr. Judy Nisbett. I think, unfortunately, we've just lost Dr. Nick Walsh. I think he had some internet issues, and I hope that he can join us in the event that there are questions. I think he just did. Let me see. Yes, he did. Okay, excellent. So again, thank you, Dr. Walsh. Thank you, Dr. Nisbett, for your presentation. I just wanted to say that I think the first presentation that we had from Dr. Walsh that.
Well, I've actually returned. I did lose connection. I'm back. So yeah.
Thank you. I was just saying I thought you lost connection. Yes. Yeah. I just wanted to say that I really like the way you presented a cascade. Quite not unlike, but a little different from the way we generally see the HIV cascade. Having presented the prevention part of the cascade and moving that over into treatment, I think that was really very interesting, and I thought it flowed very nicely into Dr. Judy's presentation when she spoke about the hepatitis B vaccine. So first question is, in many of our countries, we don't necessarily have population-based data for hepatitis B. And I see that WHO recommendation in terms of who to test really relies, and this is for generation, relies on the prevalence among the general population. So whether it's greater than 2% and greater than 5% immediate or high. And so my question is there a proxy that's used in the absence of general population information, whether it is the prevalence that we're finding among the antenatal population, for example. And so that's a question to Dr. Walsh.
So thanks very much. It's a good question. I mean, I think really in countries of the Caribbean, we're limited by the data available, but also we're limited by the response. So I think the pragmatic answer to your question is that we really need to start testing where it's possible to test, and really the first port of call would be antenatal services, so testing antenates, because that's going to identify those people who are living with hepatitis B and could potentially transmit it to their infants. So that's the first port. Once we get, once we we can identify other risk groups, people with a family history of liver cancer, people with existing liver disease from any cause, testing them for hepatitis B as the next step. And then once there is better data, epidemiological data available, then we can identify whether or not there is a particular age cohort in a particular country that we could recommend each individual having one adult test, for example. Or is the prevalence too low? Do we just have to focus on those people that have had exposures that have risk factors? So I think there's really a stepwise pragmatic approach to it. Start where it's easy to test in the populations that are easy to test, and then as the data becomes more available, then we move on to more generalized testing strategies.
Okay, excellent. So the second question is, it's really interesting that the APRI score, I think it was called, can be used to determine, your risk for hepatocellular carcinoma and so forth. What's your take on the quality of laboratory results in calculating this score?
Yeah, it's a good question. I didn't show the online calculators that are used to do this. I mean, essentially, you just need the AST and the platelet score. I think I mentioned ALT before, but so the ALT is really is the ALT elevated or not? But for the APRI score, it is the AST platelet ratio. I mean, this is platelets. The platelet, test for how many platelets you have is available in pretty much every laboratory, standard part of diagnostics, and as is the ALT liver function test. I think that these are fairly low technology tests available with pretty good accuracy in most, at least secondary health centers. So I think regarding the quality of the APRI score, I think we'd be relatively confident that the results were indicative of the true APRI score, and obviously it could be repeated over time to see if it does vary over time. But no, we think that at least the evidence shows that this is reproducible even in resource low settings. So we're confident that at this moment in time, that is the best test of cirrhosis outside clinical symptoms for resource limited settings.
Okay. So I have not a question, but a comment. Someone saying, thanks for the webinar, and they thought it was really interesting to see how well the SIP and if you'd want to comment on this, how important the SIP was in your context, or in the context of integrating hepatitis B as part of the EMTCT Plus. Any comment on
question? I'm assuming that's a question for Judy, right?
Yeah. Yes, it is.
Shanti?
Yes,
Hello?
Judy.
Yeah, can you repeat? Can you repeat? You're breaking up a bit.
I'm saying that there's a comment from a participant, and I was wondering if you'd want to address it. The participant is saying that she was very intrigued, and it was very interesting to see how much of an important role SIP has played in your experience.
Yes, SIP was really important for us because of the challenges that we had during the validation exercise for HIV and syphilis. Data was all over the place. We had to be really collecting data from the lab, from wards, from records, and the records department of the hospital. And these are all paper-based. And SIP now has really made our work so much easier. at the antenatal clinics, the nurses put the data right in, and we are able to generate reports just to find out how many of our antenatals have had their HIV test or their syphilis test. So SIP is something, if countries have not started it, I would recommend. Especially if you're moving towards elimination and being validated.
Thank you so much for that, Judy. Thank you. Thank you for that, Judy. I have a follow-up question. How much buy-in did you get from the obstetrician to be involved in this?
Well, our obstetricians are very few, so being small is really a blessing. Our obstetricians are on board with SIP, with whatever initiatives that we have introduced.
Okay, excellent. Thank you, Dr. Judy. Thank you for sharing your experience. And I think for me, once again, what it did demonstrate is that the MCH platform can be a really successful tool for integrating other public health approaches like we did for HIV, for syphilis, and now we're doing for hepatitis B. We're a little over time, so at this point, I'd like to bring the webinar to a close. And on that note, let me thank the presenters, Dr. Nick Walsh and Dr. Judy Nisbett, for really investing in this webinar and by extension, investing in the PANCAP partnership. Thank you both for sharing. Thanks to all of the participants for joining us today and for your excellent engagement and discussion. To all of us, we will receive a short questionnaire once I close the webinar off, and I ask you to please provide any feedback. Those are always useful for us. Please do join us for our next webinar scheduled August 22nd as we discuss Belize's experience in the rollout of hepatitis B vaccination as another public health approach, this time to prevent cervical cancer. Also, please stay engaged with the regional response. Follow us on our social media platforms, Facebook and Twitter. Thanks again, everyone, and do have a great day.